So I wanted us to look at a very important topic because many children actually come into the emergency department with suspected pneumonia. We get a lot of cases. So I wanted us to actually have a review on pneumonia in children. Grab a piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Mosesjrk. This is a series on my YouTube channel where we'll look at medical topics in depth. Today we're going to be looking at pneumonia in children. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon so you never miss on such amazing content every time I post. Grab a piece of paper, grab your pen, and let's go. So remember, when you talk about pneumonia, this is simply an acute inflammation that's going to be affecting the lung parenchyma, and this is going to be distal to the terminal bronchioles. So in essence, this is going to mean that it's going to be affecting the respiratory bronchioles, alveolar ducts, alveolar spaces, and interstitial tissue. Remember that pathologically, you're going to be having this consolidation, which is infiltration with fluid, exudate, that's going to be affecting the alveoli, or it can sometimes be an infiltration of the interstitial cell with the interstitial tissues with the inflammatory cells, or sometimes both consolidation as well as infiltration of the interstitial tissues. How exactly do we classify pneumonia? Well, it can be classified into four main groups. We have classification according to etiology, which can be further subdivided into bacterial, viral, fungal, and you can classify it based on the setting to which it was contracted, whether it's community acquired, hospital acquired, or pneumonia in the immunocompromised. You may also classify it according to the age group that's affected: the infants, the adolescents, the preschool going children, the school going children, and of course during the neonatal period. Then you may also classify it morphologically or anatomically or radiologically based on what you see on the X-ray. So we'll start with the etiological classification. Most of the common causes of pneumonia in pediatric age group is actually going to be attributed to viral causes, with the common viruses being respiratory syncytial virus, influenza viruses, especially influenza type A and type B, parainfluenza viruses, adenovirus, astrovirus, calicivirus, coxsackie virus, and even coronavirus, which recently caused a worldwide pandemic. Then bacterial causes are less common, but when you actually do get them, they tend to be very severe. It's very difficult to actually distinguish between bacterial type of pneumonia and viral type of pneumonia. You may have causes such as Streptococcus pneumoniae, which is also referred to as pneumococcus. So this one often causes lobar type of pneumonia, affecting the entire lobe. You may have Haemophilus influenza type B. Please do not confuse influenza virus, which is a virus, with Haemophilus influenza, which is a bacteria type B. You also have atypical causes such as Mycoplasma pneumoniae, which is very common, especially in the background of those that have acute chest syndrome. They may actually have Mycoplasma pneumoniae infection. Also in those that are school-going children, the adolescents, you want to actually have some suspicion for this. You also do have group B Streptococcus, which is very common in newborns, Staphylococcus aureus, Klebsiella pneumoniae, Legionella pneumophilia, Chlamydophila pneumonia, Coxiella bennetti, which can cause Q fever, Listeria monocytogenes, as well as Escherichia coli, which is also quite common in the neonatal period. You have some fungal causes like Pneumocystis jirovecii, which was previously renamed from Pneumocystis carinii, histoplasma, and as well as coccidioid mycosis. You also have non-infectious causes such as aspiration of food, also inhalation of oily nose droplets, liquid paraffin, kerosene poisoning, which can also cause a non-infectious type of pneumonitis. Remember that in about 40 to 60% of the cases, we actually do not find an etiological cause, and it's very difficult, like I say, to distinguish between the viral and bacterial causes, but the majority of the lower respiratory tract infections are going to be attributed to viral causes: respiratory syncytial virus, influenza type A or B, adenovirus, as well as parainfluenza virus. A helpful indicator that can actually help you predict the possible etiological cause and thereby guide your antibiotic choice is going to be the age group of the child. So what are some of the age groups and the causes that we see? So if it's a 0 to 3 month old child, if it's a newborn, suspect GBS, group B streptococcus, most common cause. You can also suspect some gram-negative rods such as E. coli, Klebsiella species, as well as Enterobacteriaceae. You may consider some congenital infections such as toxoplasma, syphilis, rubella, CMV, herpes simplex virus, and TB, quote unquote. Then you may also have intrapartumly acquired infections such as GBS, which is again the most common, the gram-negative rods like Klebsiella and E. coli, gram-positive organisms such as pneumococci and staphylococci, as well as Listeria monocytogenes. It could sometimes be a postpartum infection, which are mostly viruses, the RSV and other respiratory viruses that we talked about earlier on. Sometimes they may get an afebrile type of pneumonitis, which is caused by these atypical organisms such as Chlamydia trachomatis, Ureaplasma urealyticum, Mycoplasma hominis, cytomegalovirus, as well as the PJP. This was renamed from PCP. Then, of course, if it's between 1 to 3 months, Chlamydia trachomatis is very, very common, so you must be vigilant for this. If it's a 3-month to 5-year-old child, mostly you get the viruses, adenovirus, influenza A and B, parainfluenza, RSV. Now remember that RSV actually becomes very uncommon if someone passes the age bracket of 2 to 3 years. So beyond this age group, it becomes very uncommon. You get mostly those bacterial causes actually causing this type of pneumonia, things like Streptococcus pneumoniae, which is the most common cause, Staphylococcus aureus, Haemophilus influenza type B, and less commonly you have other things like group A Streptococcus, Moraxella catarrhalis, as well as Pseudomonas aeruginosa. Beyond this age bracket, 6 years and above, bacterial causes become far much more common. Streptococcus pneumoniae is common, Staphylococcus, but you may also get some other atypical organisms which are becoming much more common, like Mycoplasma pneumoniae and Chlamydia pneumoniae. Then you may have some viruses again like adenovirus, influenza A and B, as well as parainfluenza. Now remember that gram-negative organisms that are going to be causing pneumonia are very common in early infancy. They're very common in patients that have severe malnutrition, and they're very common in immunocompromised children. And the most common cause of pneumonia in children below the age of 5 years are usually viruses, pneumococci, and Haemophilus influenza. But of course, with Haemophilus influenza, there's a vaccine that we're giving and the advent of antibiotics, so the worldwide numbers and the ratios have actually reduced. And the most common causes of pneumonia in children over 5 years and adults are going to be viruses, pneumococci, and Mycoplasma pneumoniae, like I said, especially in school-going children and adolescents. How do you classify pneumonia according to the setting which it was acquired? So if someone actually got it at home without any immunosuppression, they are not in the hospital setup, they weren't admitted, you refer to that as community-acquired pneumonia. So in the younger children, the viral causes are the commonest causative agents, whilst Streptococcus pneumoniae is likely in older children, and Mycoplasma pneumoniae should be considered in those that are school-going children as well as adolescents. If it's in the bracket or in the confinements of a hospital, then they acquire these new symptoms that indicate pneumonia, then you refer to that as hospital-acquired pneumonia. This is a nosocomial infection. It could also be in the bracket of a child that's actually hooked up to a ventilator. They may develop a pneumonia, which is known as ventilator-associated pneumonia. It's a type of hospital-acquired pneumonia. And it could be a pneumonia in the immunocompromised. For example, patients with HIV and AIDS, they very commonly get bacterial pneumonias, and they may sometimes have fungal pneumonias with the Pneumocystis jirovecii, histoplasmosis, and coccidiomycosis that's may be seen in immunocompromised children. You may also classify it according to the radiological, morphological, anatomical classification, depending on which part is being affected. So the two most important variants are actually lobar and bronchopneumonia. So in lobar pneumonia, there is consolidation that's going to be involving the entire lobe. So the entire lobe on the X-ray actually appears white. Whilst in bronchopneumonia is going to be affecting the alveoli that are just adjacent to the bronchi, and there may be some localized or sometimes generalized patchy infiltrates. And you may also get segmental or lobular type of pneumonia involving parts of a lobe, as well as interstitial, which is going to be involving the interstitial tissue. So you just get these prominent lung markings. Risk factors include immunosuppression, which may be in the bracket of malnutrition and HIV and AIDS, prematurity, low birth weight, lack of breastfeeding, and young age group because the immune system is not yet exposed to many things and hasn't been trained, vitamin A deficiency for some reason, and of course socioeconomic factors. Just think of overcrowding, and the transmission of most of these respiratory infections is by respiratory droplets. So things like poverty, crowding, exposure to tobacco smoking through passive smoking, urban residence, as well as indoor air pollution, multiple siblings, those that have large families. You may also have some respiratory pathologies that can predispose to pneumonia. So things like family history of bronchitis, congenital anomaly of the bronchi, inhaled foreign bodies, as well as recurrent aspiration. You may also have tracheoesophageal fistulas as well as cystic fibrosis. Let me just pause the video right now because I hear a lot of noise that's actually being disturbed coming from the outside. Sorry about that. I had to actually tell the person that was playing the music because I didn't want to get a community strike on my channel. So let's carry on. So what are some of the clinical features that we often see? So remember that pneumonia actually is going to be appearing insidious and gradual, but what you have to really take note is that in the younger children, especially in the neonates, it can actually progress very quickly. Even in the very young children, those that are below, in the infants, I could say, it progresses very quickly. So whenever you get someone with respiratory symptoms that's below the age of 3 months, regardless of whatever it is, you want to admit this patient and closely monitor them. So you may actually have an insidious history that's starting off as an upper respiratory tract infection, or it may be acute with a high fever, difficulties breathing. You may also have grunting respiration. So in essence, features of respiratory distress. In rare cases, they may actually present with acute abdomen-like symptoms, which are often attributed to the referred pain from the pleura. In apical type of pneumonia, you may actually get meningismus as well as convulsions, as well as when you do a lumbar puncture in these people, you may see that the CSF is clear. Now, what's our bracket of acute presentation of pneumonia? So you get a short history of fever, usually the temperature is above 38.5 degrees Celsius, a history of a cough, a history of tachycardia, crackles when you hear the chest, as well as signs of respiratory distress. Remember, the most reliable sign is of course the tachypnea. There is a cutoff point for each of the ages, which I'll give you in the next slide. You may get difficulties breathing, as well as subcostal and intercostal recessions. You may get other features such as grunting, fever, and difficulties breathing. These are common in infants. And in older children, you may get a productive cough and some chest pains. Production of the cough is not so common, especially in the younger children, because they are unable to expectorate. And remember that pneumonia should be suspected in any child that presents with the two things. If they come in with difficulties breathing, they come in with cough. If they are very young and they come in with difficulties feeding, then you should suspect that they may be a pneumonia. Certain signs on the examination include downers to percussion, bronchial breathing, where the expiration and inspiration are of the same duration and intensity, as well as crackles that you may hear, which may suggest an underlying consolidation. Now, what is the cutoff point for what we call tachypnea or fast breathing? So if it's a child that's less than 2 months, anything greater than 60 breaths per minute is considered tachypnea. If it's 2 months to a year, anything greater than 50 breaths per minute is considered tachypnea. If it's 1 year to 5 years, anything greater than 40 breaths per minute is considered as tachypnea. And remember that the clinical signs are not so reliable in an infant, and actually the diagnosis should always be confirmed by a chest x-ray, which may either indicate that there's a lobar presentation or sometimes a widespread bronchopneumonia presentation. And certain signs that are present that may indicate that if it's a child who's under the age of 5, if they're either sleeping or resting and they have any of these signs, then this is an indicator of severity of disease. So if they have chest indrawings, if they are tachypnic, I already gave you the cutoff points in those that are below 2 months, those that are between 2 months to a year, and those that are between 1 year to 5 years. If there's cyanosis, so you make sure that you examine the lips, the buccal cavities, the fingertips. If there's nasal flaring, if the child refuses to drink, if the child is abnormally sleeping or very difficult to wake up, if there's any stridor, a hoarse noise that's heard on inspiration, or a whistling sound that's heard on inspiration, if there is grunting, which is this repetitive noise produced by partial closure of the vocal cords on expiration, and if there's severe malnutrition, these are all indicators of serious illness. This is how we actually classify pneumonia based on severity. So it's divided into those that are less than 2 months and those that are between 2 months to 5 years. So for those that are less than 2 months, it's actually divided just as severe and very severe. So if they have severe chest indrawings, tachypnea, they have a severe pneumonia. If they refuse to eat, they're convulsing, they have they're abnormally sleepy or difficult to wake up, they have a fever, or they're hypothermic, then that's considered as a very severe pneumonia. In the much older age group, if it's mild, if there's just a tachypnea, it's considered severe. If there is chest indrawings, it's considered very severe. If they're not able to drink, if there are convulsions, if they're drowsy, and if there's malnutrition, then we consider it as very severe. What's our indication for admitting our children? If it's an infant or an older children, as long as there's cyanosis, the oxygen saturation is less than 92, admit these patients. If they have an increased respiratory rate, regardless of whether they are cyanosed or not, admit them. If there are features of respiratory distress such as subcostal recessions, intermittent apnea, grunting, as well as agitation and restlessness, admit these patients. In the infants, if the fever is greater than 38.5 and they have poor feeding or vomiting, admit them. And all children that are less than 3 months, regardless of the severity, should be admitted because they tend to deteriorate very quickly. You also want to look out for signs of dehydration in the older children, because remember, every time someone is breathing out, they're losing some water. There's also some associated systemic manifestations, any severe underlying disorders such as immunodeficiency, any recurrent pneumonias, any failed previous antibiotic therapy. You want to admit these children and closely monitor them on the ward. What investigations do we want to do? So we want to order some basic blood investigations. So get a complete blood count or full blood count. Generally, when you have an infection, there will be a raise in the white blood cell count with predominance of the polymorphonuclear cells. Pretty much your neutrophils will be increased, and this is going to be pointing towards a bacterial infections. But sometimes you may actually get a very low white cell count. This can either suggest that there's a viral infection, or it can suggest that there's an overwhelming infection. Another thing that you should look out for is the platelet count. You may also get an ASR, which is non-specific and may be raised. Get a blood culture. This is actually the non-invasive gold standard investigation of choice to determine the etiology. But of course, it has very low sensitivity, and only about 10 to 30% of the cases actually are positive. Remember, in my pediatric rotation, we only, I think, had 2 cultures that actually came out positive from all the cultures that we did for suspected sepsis, and that wasn't even with pneumonia. They had some respiratory symptoms. And we want to do this cultures in severe pneumonia, or if they are not responding very well to the first line antibiotics, get our urea electrolytes and creatinine, because there's a risk of syndrome of inappropriate ADH secretion. Our ABGs if they are available, but if they're not, just pulse oximetry is actually good enough to actually even indicate the severity of the condition. In some cases where we are suspecting atypical pneumonia, such as Mycoplasma pneumoniae, chlamydia, Legionella, Moraxella catarrhalis, we can actually order for serological tests. In the acute phase, if you get a titer that's greater than 1 to 160, or if you get 2 samples that are about 2 to 4 weeks apart and there's a rise that is 4-fold in the sample that is 2 to 4 weeks apart, then this is actually a good indicator that a patient may have Mycoplasma pneumoniae. Remember, you should consider this in children that are aged 5 years or older, especially those that are going to school. If there is a significant pleural effusion, actually do a pleural tap, which is a diagnostic pleural tap, and send the pleural fluid for analysis. Do not forget to get a chest x-ray. Although this is indicated in certain cases, we do not always get the x-ray if we don't have the facility, and if the pneumonia is mild, there is no need for the x-ray. If it's viral, you may see some hyperinflation, some perihilar infiltrates, you may see peribronchial infiltrates, you may see hilar adenopathy, you may sometimes see atelectasis. With the bacterial, you may see alveolar consolidation. With Mycoplasma, you see interstitial infiltrates. With TB, you may even get some hilar lymphadenopathy. And with pneumocystis, you may get this reticular infiltrates, kind of like an angel wing pattern. How do you manage these children? Remember that management largely depends on the clinical, laboratory, as well as the radiological findings, but also considering the age of the child, the local epidemiology of the pathogens that are present that are affecting the respiratory system, along with their resistance and sensitivity to certain drugs. And remember that the severity of the pneumonia, the drug cost is also going to be impacting and affecting which drugs we're actually going to be using. Majority of the infections are actually going to be caused by viruses and actually do not require antibiotics, but in most of the cases I've seen children being empirically given antibiotics. So what antibiotics are we going to consider? So generally, if we are considering that these antibiotics these organisms are beta-lactam sensitive, or they're susceptible. So Streptococcus pneumoniae, Haemophilus influenza type B, Staphylococcus aureus, group A, Streptococcus. So these can actually work against those that have the beta-lactam rings, which are the penicillins, the cephalosporins. So with pneumococcus, you can actually use either penicillins or cephalosporins. With Haemophilus type B, you can use ampicillin, chloramphenicol, or cephalosporins. With Staphylococcus aureus, cloxacillin works best. Then with group A streptococcus, penicillins, and cephalosporins. But remember, these things always change because sometimes sensitivity does change and certain organisms in your area can actually be resistant to these drugs. So this actually should be reviewed and checked at regular intervals. Then with Mycoplasma pneumoniae, you want to use the macrolides. These are atypical organisms, so things like erythromycin, azithromycin. Chlamydia pneumoniae, you want to use again the macrolides as well as Bordetella pertussis, which is what is causing our whooping cough. We want to target that with macrolides. So our suggested lines of treatment include our first line drug, which are the beta-lactams, the benzopenicillins, the moxicillin, amoxicillin with clavulanic acid. You also have ampicillin. Then our second line, our cephalosporins, pretty much our cefotaxime, cefuroxime, ceftazidime. Our third line drugs are our carbapenems, which is imipenem. Then our other agents that we use are aminoglycosides like gentamicin and amikacin, which can target these gram-negative organisms. Then remember that if we admit the child, we want to give our antibiotics via the IV route. And as a rule of thumb, in severe cases of pneumonia, we want to actually combine a second or third generation cephalosporin with a macrolide to also target any other organism that may be atypical. Then we want to consider switching the drugs if there are no signs of recovery or if the patient actually remains toxic and ill-looking or there are spiking temperatures after 48 to 72 hours of adequate dosing and adequate frequency of the drugs. If they're not improving, then you can actually escalate. Then staphylococcal infections, as well as infections that are caused by gram-negative organisms such as Klebsiella, are actually being frequently reported in children that are actually malnourished. So here's a practical guide. Remember, pneumonia is largely divided into those that just have a mild pneumonia, those that have a severe pneumonia, and those that have a very severe pneumonia. Remember, those that have a mild pneumonia just have tachypnea. If they're less than 2 months, cutoff point is 60 breaths per minute. If they're 2 months to a year, cutoff point is 50 breaths per minute. If they're 1 to 5 years, cutoff point is 40 breaths per minute. So if their saturation is actually less than 92%, we want to give them benzopenicillin, so we want to admit them. But otherwise, if their saturations are okay, we can treat them at home. So we give them amoxil at 25 milligrams per kg 3 times a day. This can be given as a syrup for 5 days. Obviously, you want to tell the mother to come back after maybe like 2 days to assess whether this child is improving, and you should counsel the mother on signs of deterioration and when this woman should come back and how to know if the child is not really improving. If they are between 0 to 3 months, benzopenicillin 50,000 international units per kg per dose QID, and this is with or without gentamicin 7.5 milligrams per kg once a day, or you can give it in 2 divided doses. For those that are greater than 3 months, we just cover them on benzopenicillin. That's our Xpin at 50,000 international units per kg per dose 4 times a day. Then for those that have severe pneumonia, these ones also have chest indrawing, so we want to admit them and we want to start them on oxygen and give them either our benzopenicillin at 50,000 international units per kg per dose 4 times a day. We can give ceftriaxone at 80 milligrams per kg per dose once a day, or cefotaxime at 50 milligrams per kg QID. If they have any of these features, central cyanosis, they are unable to drink, they severe respiratory distress with head nodding, then that's already a very severe pneumonia. So we generally want to admit the patient, give them oxygen, then start them on antibiotics. Our benzopenicillin at 50,000 international units per kg per dose 4 times a day, combined with gentamicin at 7.5 milligrams per kg once a day, or in 2 divided doses. Or alternatively, we can just put them on ceftriaxone at 80 milligrams per kg per dose once a day, or cefotaxime at 50 milligrams per kg QID. Remember that in the neonatal period, we want to avoid ceftriaxone because of the risk of displacing bilirubin from albumin and the risk of kernicterus. So we usually use cefotaxime. So in infants with HIV infection or HIV exposure, and you're suspecting that they may have fungal infection, we may consider PCP therapy with high dose, either IV or oral cotrimoxazole, at 20 milligrams per kg of trimethoprim, and this should be included to your regimen. Macrolides should be considered in those that are school-going children and adolescents who are not improving on the first line. So we can give them erythromycin if it's 1 month to 2 years, 125 milligrams 4 times a day. If it's 2 to 8 years, 250 milligrams 4 times a day. If it's 8 to 18 years, 250 to 500 milligrams 4 times a day. We can also consider azithromycin. Luckily now we do even have an azithromycin suspension, or rather the oral formulation in the liquid form. Then if it's 6 months to 2 years, give it a 10 milligrams per kg once a day. If 3 years to 7 years, 200 milligrams. If it's 8 to 11 years, 300 milligrams. If it's 12 to 14 years, 400 milligrams. And if they're greater than 14 years, 500 milligrams once a day. Of course, we give this for 3 days. The erythromycin, we can actually give it for 5 days. What are some of the general measures that we want to do for children that we admit? So we keep their saturations above 95 at least. So we can give them oxygen via a face mask or via a nasal cannula. You can escalate in a way. I will leave a video tagged at the end of oxygen therapy. It actually should be given to all children that are restless, those that are tachypnic, those that have severe chest indrawings, and those that have cyanosis or they're not tolerating feeds. And giving oxygen has actually been shown to improve the mortality rates of those that have severe pneumonia. Then of course, don't forget to put them on fluids. Add something that has dextrose, because this person is breathing in and out, their respiration rate is high, they're losing a lot of water, there's a risk of dehydration, there's a risk of hypoglycemia, so add some dextrose. But again, do not give them a lot of fluids, because there's a high risk of syndrome of inappropriate ADH secretion, especially in those children that are hypoxic. So we generally want to restrict the fluids to less than 2/3 of the maintenance fluid to avoid this overhydration. And if they're in significant respiratory distress, actually hold the fluids, the oral fluids, because there's a risk of aspiration. Cover them on an antipyretic and analgesia. Paracetamol can suffice at 50 milligrams per kg QID. Then chest physiotherapy can also be done. So this helps with removal of these tracheal bronchial secretions. It helps remove the airway obstruction. It helps improve the gaseous exchange. It helps also reduce the work of breathing. But there is no clinical evidence that chest physiotherapy should actually be routinely done for all patients. We also want to monitor their vitals. And one important thing is that avoid giving cough suppressing medication. The cough syrups, avoid that, because they may actually interfere with the clearance of the airway. So for some patients that actually come in with mild pneumonias and they just have fast breathing, there's no chest indrawings, you can actually give them oral antibiotics. That's our amoxicillin, which we talked about earlier on. We want to educate the parents or the caregiver about the management of the fever, the prevention of dehydration, and as well as identifying signs of deterioration and when to come back. Generally, they should return in about 2 days for a reassessment, or earlier if the condition is actually getting worse. What are some of the complications? They're going to be including pleural effusions, septicemia, bronchiectasis, empyema thoracis, which may need an ICD, as well as a lung abscess. This is often following staphylococcal pneumonia. Before we actually end the lecture, I want us to talk about 2 important things. The first thing is staphylococcal infections. Remember that these are going to be responsible for a small proportion of the cases, and they need a high index of suspicion because they have the potential to actually rapidly deteriorate. It's actually very common in infants and it has a significant risk of mortality. But when you get a radiological X-ray, you may see multilobar consolidations, you may see cavitations, you may see pneumatoceles, you may see spontaneous pneumothorax, empyema, you may even see some pleural effusions. These ones are usually treated with high-dose cloxacillin at 200 milligrams per kg per day for a longer duration than those that just have a typical pneumonia. And of course, drainage of empyema actually results in good outcome. The other thing that I want us to look at is necrotizing pneumonia and pneumatoceles. Remember, this is going to be as a result of localized bronchiola as well as alveolar necrosis. Many bacteria can cause this, but commonly it's common with Staphylococcus aureus, it's common with Streptococcus pneumoniae, Haemophilus influenza, Klebsiella pneumonia, as well as E. coli. We generally want to give them IV antibiotics until the child shows some signs of improvement, and we can actually even give them for a duration of about 3 to 4 weeks. That's almost even a full month. With the most pneumatoceles, they actually tend to disappear, and there is actually evidence of radiological resolution within the first 2 months, but they may even take as long as 6 months to actually completely disappear. I really hope you enjoyed this lecture on pneumonia. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss such amazing content every time I post. To Zambia and beyond, I'll see you in the next video. Until next time, bye-bye.